Hello, my name is Jorge Cortes from the Department of Leukemia at MD Anderson Cancer Center. And I want to discuss with you today some of the questions that I get from my colleagues and that are treating patients with CML. And one of them has to do with the sensitivities of the different CML therapies to various mutations, and including the T315I. And this is very topical because, of course, now we have many tyrosine-kinase inhibitors and even one drug that's not a tyrosine-kinase inhibitor, but it's also approved for the management of CML. And we know that with imatinib, one of the most common mechanisms of resistance is mutations in the ABL kinase domain. And there's more than 100 different mutations that have been described with imatinib. We learned shortly after that second-generation tyrosine-kinase inhibitors such as nilotinib, dasatinib, and more recently bosutinib can work in most of the mutations that cause resistance to imatinib. They work in the laboratory, they work in vitro, but importantly, they also work clinically. Now, there are some mutations for each one of these drugs that cause resistance to these agents. And they're a little bit different, and that's important because it helps us perhaps decide what treatment may be more appropriate if we have one of these mutations. For example, with mutations such as F359 or with some of the P-loop mutations, nilotinib is not as effective in the laboratory and in the clinic. Whereas other mutations such as the V299L or the F317L, dasatinib and bosutinib, which have a very similar pattern of sensitivity to different mutations, they may not be as effective. Importantly, none of these three drugs, and the four if we include imatinib, work against the T315I mutation. So we know that if we find that mutation, none of these drugs is going to be effective, and that's been the case in the clinic. There's been studies that if you use the TKI that has better sensitivity against the mutation that you're treating, the outcome of these patients is going to be better. The response rate is going to be better. The progression-free survival is going to be better. Now, more recently, we've had ponatinib, which is, I call it a third-generation tyrosine kinase inhibitor, and the main aspect that differentiates it against the other drugs is that it does have activity against the T315I mutation. Now, importantly, it also has activity against all of the other mutations against which it has been tested. So it really has a broader panel of activity against all the different mutations, and in the laboratory also prevents the emergence of resistant clones. So this is why ponatinib is called a pan-BCR-ABL inhibitor, because it inhibits as well the BCR-ABL without mutations as it does the BCR-ABL with T315I or any of the other mutations. And finally, omacitaxin. This is not a tyrosine kinase inhibitor, so not having a specific mechanism of action like the others, it is not affected by the presence of any of these mutations, and it has shown activity against patients that have failed 2 or 3 tyrosine kinase inhibitors with any mutation, including the T315I, with about 20% of patients responding. So I think that the knowledge of this information can help define what drug may be more useful for, predicted to be more useful for a specific patient. Thank you.